Okay, let's continue with Chapter 43, Part 3, Cancer. Okay, we're going to talk about childhood cancers, differences from cancers in adults. It's not common, but some neonates and young infants have cancers such as CNS tumors, neuroblastomas, leukemia, retinoblastoma, renal or hepatic tumors, sarcomas, teratomas. They're diagnosed usually right after birth. Because these cancers occur so soon after birth, it is suggested that they are the result of some inherited condition or there is a genetic susceptibility. Most adult onset cancers are epithelial in origin, whereas in children they originate from non-epithelial or embryonic cells. Adult cancers are slow growing and result from exposure to carcinogens over time. Childhood cancers are fast growing, and a healthy child can appear ill over a period of days or weeks. Adult cancer is often the result of poor diet or lifestyle choices, genetic causes, or the result of oncogenic responses in the body. Childhood cancer is often embryonic. It occurs during the development of the fetus, or oncogenic in origin. A child's lifestyle has very little to do with the development of cancer. In the first month of life, nonspecific immunity, um, such as your phagocytes, your mononuclear leukocytes, your PMN cells, your natural killer cells, and your complement proteins, is immature. This system is not ready to take on any cancer or to fight it off. Nonspecific immunity is also impaired if the child was born premature or small for gestational age. For a specific immunity, your T cells are supposed to attack a specific invader. Those T cells are immature in babies and immunoglobulins are below adult levels, which make the baby prone to bacterial and viral infections. Apoptosis is normally takes care of cell overgrowth, but because most all cells in children are growing and dividing quickly, they're supposed to be growing, the process of apoptosis is not always triggered. The bottom line is that in children, the immune system is not quite ready to even take on or to fight cancer. Okay, so let's talk about some neoplastic disorders. It's the leading cause of death from disease in children past infancy. Almost half of all childhood cancers involve blood or blood forming organs. We have leukemia and lymphomas. So, leukemia is the most common form of childhood cancer. It's an abnormal proliferation of the white blood cells. The two most common types are ALL and AML. First, I want to talk about ALL, acute lymphoblastic leukemia. Counts for 25% of all childhood cancers and 78% of all leukemias. Peak age onset is 2 to 3 years. It's more common in Caucasians and boys. Represents 35% of all cancers and 78% of leukemias in children. Then we have AML. That's the acute myelogenous leukemia. It's a leukemia from myeloid cells. It's common usually in less than 2 years of age or adolescents, males, Asian Pacific Islanders, Hispanics, or Caucasians. Represents about 17% of all leukemias in children. Okay, so looking at the pathophysiology, cause can be varied. Possible causes include infectious agents, genetics, chromosomal defects such as Downs, immune deficiency states, fetal exposure to ionizing radiation, or chemotherapy. Instead of going through the normal mitosis to make new cells, these crazy cancer cells clone themselves and fill up the bone marrow with the abnormal cells. So basically what happens is the cancer cells come in, they take over the white blood cell function. They don't take time to make the correct cells. They just make more bad clones, which take over the good white blood cells. It hijacks the bone marrow and shuts down the production of the red blood cells and the platelets. So basically you have less white blood cells, you have more of the altered cells, cancer cells that have taken over. Interestingly enough, although the white blood cell production is high, the actual white blood cell count in lab is low. These leukemic white blood cells are not vicious and mean. They don't try to attack things, but it's kind of like survival of the fittest out there, so there's a competition for the metabolic resources. Stem cells in the bone marrow produce large numbers of these immature white blood cells that do not function normally because remember they're altered. These abnormal cells spill from the marrow into the circulation where they replace the normal white blood cells, leaving the body exposed for infection. Takes away the normal immune functions. These abnormal cells take over the marrow and replace the stem cells that make red blood cells and platelets too. Eventually, this will cause anemia and thrombocytopenia. So we can talk about clinical manifestations. They could have fever, pallor, lethargy, malaise, anorexia, petechiae, or frank bleeding, and joint pain. These are cardinal signs of bone marrow failure. They can have the enlarged liver, the spleen, the lymph nodes. If there's CNS involvement, they can have a headache, nausea and vomiting, papilledema, sixth cranial nerve palsy. The testicles, spinal cord, or bone marrow are common for infiltration. If the bad cells invade the testicles, they can swell and often they're not painful. Let's talk about diagnosis. It's based on lab work. Blood counts reveal anemia, neutropenia, thrombocytopenia. When they do a bone marrow aspiration, it will show immature and abnormal cells. They'll also see elevated serum uric acid, calcium, potassium, and phosphorus levels. Okay, let's talk about treatment that involves chemoradiation. You can also look at Nursing Alert on page 1382 of your textbook. First, I'm going to talk about the induction phase is 4 to 6 weeks. Some of the medications could be prednisone, vincristine. Make sure you review the medications given in this phase. Maximum cell death occurs during the induction phase. Cells that do survive this phase are more resistant to the treatment. Then we have, after about 3 to 4 weeks, when a remission has occurred, then CNS prophylaxis begins in conjunction with cranial radiation. Radiation and additional medications used for CNS disease, as well as intrathecal methotrexate. During the intensification phase, the goal is to eradicate any residual leukemic cells, followed by delayed intensification, in which the goal is to prevent any resistant leukemic cells from cloning. Drugs in the delayed intensification are used to target leukemic cells that may have survived. Let's talk about the remission phase. It's basically to maintain remission. Maintenance therapy continues for 2 to 3 years, causing a decreased immunity and an increased risk for infection. Okay, so let's talk about hematopoietic stem cell transplantation, also known as bone marrow transplant. It's used to treat severe combined immunodeficiency syndrome, aplastic anemia, or leukemia. Stem cells exist primarily in the bone marrow. It also presents in the peripheral blood and the cord blood. And then hematopoietic stem cells can grow into the new body cells. There are two types of bone marrow transplantation. There's autologous and allogenic. So autologous child's own marrow is taken, stored, and reused or reinfused after chemotherapy. Allogenic is a donor, usually a sibling, has the compatible human leukocyte antigen, HLA, and donates the cells to the child. If there's not a sibling match, then they use an unrelated donor from the registry or cord blood bank. Process begins with chemotherapy and or total body irradiation. Goal is to destroy circulating blood cells and the diseased bone marrow. It lasts 4 to 12 days. Child is at high risk for infection, so they are in reverse isolation. Child is transfused with donor cells, and the child is still without any immunity for 10 days post bone marrow transplantation. If successful, the cells implant in the bone and they begin to grow. It takes 2 to 4 weeks for the donor cells to proliferate and mature. Medications are used to stimulate red and white cell production, and then they are still at a high risk for infection. What results is a healthy bone marrow that will be capable of making new cells. So the nursing management for bone marrow transplantation is to prevent infection. You want the protective reverse isolation, wash your hands, and avoid fresh fruit and flowers. You also want to encourage family to wash their hands. You want to make sure you control bleeding, limit invasive procedures, no intramuscular injections or rectal temperatures. Maintain pressure on any injection site for at least 5 minutes, and then transfuse with red blood cells or platelets as needed and ordered. You want to maintain nutrition and hydration, monitor for signs and symptoms of rejection, graft versus host disease, and then you are also going to provide emotional support. Continuing with the care management, care is centered around managing side effects and safe administration of medications, monitoring labs. So, some of the things you're going to do is manage problems of drug toxicity. They'll have signs and symptoms such as nausea, vomiting, anorexia, mucosal ulceration, neuropathy, hemorrhagic cystitis, alopecia, mood changes, and moon phases. I want you to review the YouTube video that is also included in these lesson content under resources. When discussing lymphoma, this is the most common groups of malignancies in children. It's divided into about two categories. There's Hodgkin's and non-Hodgkin's, and then they can be further divided from there. Hodgkin lymphoma is more prevalent among children 15 to 19 years of age. It is a lymphocytic predominance, it's nodular sclerosis, it's mixed cellularity, and it's lymphocytic depletion. Non-Hodgkin lymphoma is more prevalent among children less than 14 years of age. So when you look at Hodgkin's lymphoma, it's a neoplastic disease originating in the lymph system, primarily involves the lymph nodes. Hodgkin's may spread predictably to non-nodal or extralymphatic sites such as the spleen, liver, bone marrow, or lungs. It can be further broken down into the four following categories. There's lymphocytic predominance, nodular sclerosis, mixed cellularity, and lymphocytic depletion as earlier indicated. The Ann Arbor staging system assigns a stage based on the number of lymph nodes that are affected. There's a presence of extranodal disease and a history of symptoms. Patients are either classified as A or B. Classification A is asymptomatic. Classification B is temperatures of 38 degrees Celsius or higher for 3 consecutive days, night sweats, unexplained weight loss of about 10% or more over the previous 6 months. Clinical manifestation of Hodgkin's disease are enlarged cervical or supraclavicular lymphadenopathy, and then there's cough or abdominal discomfort or even anorexia. Diagnosis is usually done with a lymph node biopsy. There's a presence of Reed-Sternberg cells. This is characteristic of Hodgkin's disease. And then, of course, a bone marrow aspiration will be done with an advanced disease. When you talk about therapeutic management, usually radiation is done, and then the most common side effect of radiation is fatigue. This is hard for children because they can't keep up with their peers, so they will push themselves to the point of exhaustion. The other big thing to consider, specifically in pediatrics, is sterility from the chemo or the radiation. Sexual function is not altered, but the ability to reproduce in life may be affected. Puberty may be delayed in children that are undergoing cancer treatment. Then there's the potential for chemotherapy. Prognosis usually is a long-term survival that is very excellent. For care management, we want to prepare the child and the parents for diagnostic procedures and, of course, provide education on the side effects of chemo and radiation, and then provide family support. Now let's talk about non-Hodgkin lymphoma. In contrast, non-Hodgkin lymphoma occurs more often in children. The classification is different because the disease itself is different. This is because the disease usually diffuses rather than nodular. The cell type is undifferentiated or poorly differentiated. Dissemination occurs early. often and rapidly. Mediastinal involvement and invasion of the meninges is also common. Non-Hodgkin lymphoma has similar diversity as seen in leukemia. Classification is based on the histologic pattern. Is it lymphoblastic, Burkitt, or non-Burkitt, and large cell? Immunologically, these cells are classified as T cells, B cells, or non-T or non-B cells. Staging is often unnecessary because of the widespread dissemination of the disease. The clinical manifestations are the same as Hodgkin lymphoma and leukemia. In non-Hodgkin lymphoma, there may be organ-related symptoms due to the enlargement of the adjacent lymph nodes to the surrounding organs. Patients can experience intestinal or airway obstruction, cranial nerve palsies, or spinal paralysis. Diagnosis is based on biopsies, imaging studies, and bone marrow studies. Treatment is the same, chemo and radiation. Chemo phases are like those of the leukemia, and prognosis is good. About 80% of children can be cured, even with widely disseminated disease. This concludes Chapter 43, Part 3.